and will be sent to everyone after we get our communications approval. We have recordings also on our website, but there is a lag. They're a few months behind. But if any of these topics are of interest to you and you want to go back for a refresher, you can go to our website. Throughout this presentation, there will be live links to the resources. And so you can just click on those links once you get a copy of the slide deck and be able to tap into those resources too. All right. So let's start. Let's talk about what we need to brace ourselves for. We gave our respiratory preparedness talk back in October, and things were, you were thinking that we'd have maybe a more milder flu season this year because it was really a terrible flu season last year, and COVID and RSV would be fairly status quo. But all things change in the world of infectious diseases, and you've heard in the news about a new variant of the seasonal flu. And I think there's an important distinction between novel flu, which can get a little confusing, and the new flu variant of the seasonal flu. And there something to just remind you that we usually see flu A in the beginning of the flu season. Flu B becomes a little more prevalent later. And most of what we're seeing right now is this variant, this subclade K of the H3N2. H3N2 is the parent strain that's covered in all vaccines. And there's concern about maybe there are too many mutations on subclade K to render the vaccine not particularly effective. So there is some good news on that front. The most recent data that has come out from the UK on their effectiveness, because they went through their flu season a little earlier than we did, it is really effective in children, 70 to 75% effective in children to protect them from hospitalizations, to prevent hospitalizations. 30 to 40% in adults. And I will tell you, most people might poo-poo that, but a 40% risk, lower chance of ending up in the hospital with the flu was worth it to me. I got my flu shot. I made sure my child got their flu shot. So it is really important before you think about ignoring that flu vaccine alert that pops up on your screen when you're seeing patients or you're caring for the community. Don't ignore that this season, please. This is, I think, important. If you think, are we there yet? Has flu arrived? Yes, we are officially in flu season. We've hit that threshold. We hit it last week, and unfortunately, our preparedness has not matched the arrival of the flu season. Our vaccination rates are still pretty low. And what's sad is that the first child in the US has already died from flu, and we barely started our flu season. This was this elementary school child in Colorado. So this is not time for us to be complacent about it. A very sobering reminder, last season, over 100 children, when it was a very severe flu season, experienced encephalitis from flu. It's called IAE. And it was pretty devastating. A fifth of those children died, didn't make it through. And these were young, under 5, healthy children. So the next time you're thinking, oh, is this 30, or should I even have this conversation about having this healthy 30-year-old a flu shot? Think about it this way. When we have less flu in the community, our most vulnerable, our children and our elderly, they have less flu too. And when they have less flu, they have less flu complications. They have less flu, as I said, deaths and just in general burden. So the flu shot is not just something you do for yourself, it's something you do to protect those around you too. So I think I'd want us to go into the season with that, with a reminder of that fact. And to simplify some of the chaos around respiratory vaccines, Illinois has really thought through what needs to be done next. And we have a very robust, well-respected Illinois Immunization Advisory Committee that met in September, made a decision about who needs to be vaccinated. And we have very concise, clear guidance, as well as a one-pager document that's on our website. Again, all these links are live. If you find them useful tools, please take advantage of those. And where we published that guidance in September, but we also, as some of you may be aware, have the law HB 767 that just was signed, or I would say a bill that was signed into law. And consequent to that, our IAC met again on Tuesday, reaffirmed these recommendations, as well as provide clarification of what needs to be done about hepatitis B. And Dr. Sir is going to unpack the hepatitis B part of it. And for the most part, our recommendations are truly in line with what we're seeing at the federal level. But we did want to make sure that we sort of emphasized one group, and that was the children who are under the age of 2. And this group is really critically important because we are now seeing in this endemic stage, this group of children has a higher rate of hospitalization than those who are over the age of 65. You cannot necessarily ignore the children who are in this group and consider them an optional risk group for those who need to get immunized. That's not what the epidemiology and the data are showing us. So we're not doing great effort. We finally, in October, when we presented, we didn't have our flu dashboard available yet, but we do now. And our rates are pretty low for our children. And we understand that the federal vaccine for children's program no longer has COVID vaccine as a required vaccine, which can also reduce the overall just access to this vaccine. But to bolster that, we are now providing this season free mobile clinic service for fall respiratory viruses to local health departments. So if you think you are in a jurisdiction where you could use this mobile service, please contact your local health department and let them know that the service is available for the next few weeks. And as long as we can keep it going for this season. Now, we also know that several pediatric offices are not able to bear the costs of containing the COVID vaccine. And so we are also having our local health departments giving them their option of directly procuring COVID vaccine at no cost to the state. And we want to make sure that our children specifically have the opportunity to get protected. But again, there are risk groups across the entire spectrum who would continue to benefit from protection. We've also launched our statewide standing order for COVID-19 so that people can get it at pharmacies and at clinical sites, especially if there's any concern about access in that area. So please, again, these are live links. Tap into them if you think they'll be helpful and you can leverage those for your community. So the last of the big three, we think about COVID, flu, RSV as the big three for the season, is RSV. And, the good news is we have really effective products out there to prevent RSV. Nirsevimab is pretty effective, 80% effective in preventing ICU admissions for infants in that first season, 90% effective in preventing hospitalizations. But only 30% of the kids got it. Now, of course, though, if their moms got it, they don't need it. However, it's much harder for us to estimate the rates of how many pregnant individuals are successfully even getting vaccinated for that. And so we are trying our best to make sure that at birthing hospitals, when you leave, you get that shot. So if you are working or affiliated with a birthing hospital, and looks like there is an echo, so I don't know if there are others who are unmuted. So please make sure you are muted, and hopefully there won't be too much echo moving forward. Thanks, Dr. Lin. So I just want to make sure that if you are affiliated with a birthing hospital, please make sure your administrators, your providers, and your patients are educated about the importance of this and the effectiveness of this season. And our sister state agency, our colleagues at HFS, our Medicaid oversight agency, have also just issued a provider notice to address some of the barriers related to RSV vaccine. And so the provider notice was issued in November. No prior authorization is required. No additional verification of gestational age is required for the RSV vaccine in pregnant people. Now, just so you know, you still have to verify gestational age. You just don't have to submit any additional documentation. So we do want to hear from the community if they are experiencing barriers to getting these shots in arms. These vaccines don't work if they don't, you cannot get them in arms. So my charge to each and every one of you is to please make sure that everyone, your vulnerable, people in your community are all protected as we head into the season. And it's not like we didn't have enough with the big three. It's like, what else is lurking? Unfortunately, a lot else is lurking. And I'll unpack a little bit about novel flu, but just for awareness. Just in the past month, mostly in poultry, there have been 1 million birds have been affected in 7 states, some of them neighboring Illinois. And we, we have been sort of a little complacent with this in our minds, and I'll talk about some resources in dealing with novel flu if it does strike us in a more a serious way moving forward. Now, pertussis is something I feel like you may have heard about in the news. Why are children in 2025 dying of pertussis when we have a vaccine and we have treatments too? This is something that I feel is a failure of our healthcare system in making sure that these children are not protected. 15 deaths, 10 among infants. And this also speaks to the protection these infants get through during pregnancy, through their mothers, as well as in their households. Unvaccinated household contacts of pregnant people or infants do need to also catch up on their vaccine. And unfortunately, look at this, our rates, the rates have gone up pretty much in tandem to the case rates have gone in tandem to the vaccination rates going down in schools. And this is Tdap, not DTaP. DTaP has also gone down, not as significantly, but steadily. And Tdap has gone down pretty dramatically pre and post pandemic. Now we're at the threshold. This is based on the school vaccine rates of less than 95%, only about less than even 92% for coverage. And so I want people to pay attention because this is a powerful tool to protect us. It's not just from pertussis or whooping cough, as some people think about it. It's also from diphtheria. And if you haven't practiced in outside of the US, you might think diphtheria is a non-entity, but it's not. There are global outbreaks. And if you think pertussis is bad, you truly do not want to ever experience diphtheria or have someone you love or your patients experience diphtheria. It is devastating. And there are global outbreaks happening. Dr. Spencer, who you will hear from soon, is really focusing also on understanding and refining the risk from global outbreaks to Illinois and determining what our response plan should be. But just remember, World Cup is around the corner in a few months, and we really need to think about, let's protect ourselves with every single thing we got to protect us, to make sure we're protected from spillover events from vaccine preventable illnesses. So just a quick line on what do we do about avian flu. We really have a great toolkit out there and want to just shout out to our communications team. We have a dashboard. We have information for clinicians, for livestock owners, for veterinarians, for pet owners, and whatever applies to you, make sure you take advantage of this resource and understand what's in this toolkit. Now, I cannot tell you the number of times during the past year we had Good Samaritans pick up dying Canadian geese, put it in the car in the cold of the winter, windows all shut, and drive them to a clinic for care. Please do not do that. And if you have patients or community members who you think need to be educated to not really handle dying birds, again, especially the kind of birds that we know are vulnerable to bird flu, then make sure they have the tools to get educated. And we have 2 products out there. One is like, what do you do? How do you dispose of? What's the right PPE to dispose of dead birds? If it's more than 5 in a pretty narrow geographic location, call the Department of Natural Resources. Flag it for them because they will flag it for us, and we update our information on our dashboard too. So just know these resources exist. And I'm going to go past germ theory for a little bit. It's not just about the bugs. It's really about extreme weather events. And, Dr. Kunar will go a little bit more into some of the chronic diseases and other key things, including cancer. But here, I just want to talk for a second about extreme weather. If you care for vulnerable people, especially those who are unstably housed, cold can be devastating for them, and there's a pretty high rate of mortality from just excessive cold. So make sure as clinicians you're aware of where the heating centers are. It's not just those who are unstably housed. People who are in greater economic difficulty probably don't have access to heat, not just housing during the season. And so please just, you can see it all over Illinois. Just know that this resource exists if you need to point your patients, and ask your patients the right questions. Ask them if they actually are going to experience any weather vulnerabilities this season. And if you want handouts, this is just a great resource. I'm not going to go over all the content. It's just to show you that weather.gov or NOAA has resources for clinicians. It's just for you to get educated on what are the signs of cold weather injury, frostbite, etc. But also things you can hand out to your patients so that they have a preparedness plan, especially if you have patients in these categories who are newborns, elderly, have chronic disease, outdoor workers, or are unhoused. And again, don't forget your pets and your plants, whichever, both are precious, and as we deal with this upcoming season. And with that, I'm actually going to stop sharing and turn it over to Dr. Suh, who will take us through a journey on how to protect our children and what we've learned this past year.
Great. Thank you so much, Dr. Barnes. Let me share presentation. All right. So we have been dealing so many things related to child health this year. But here is a quick recap. We're going to talk about immunizations, congenital syphilis, lead poisoning prevention, and behavioral health very quickly. This should all be a review from some of the things that we've covered in our prior Fast Facts. So starting with immunizations, I know I am preaching to the choir likely, but vaccines save lives. They have saved millions of illnesses, millions of deaths. They've saved our country trillions of dollars. Vaccines work, and we really need to do a good job of making sure our communities understand why we are promoting vaccines. So we started this year with the measles cases and the outbreaks that were happening across the country. And so we were really focused on childhood vaccinations in general, but measles in particular. And so don't forget, we have this school vaccination coverage dashboard. We are eagerly awaiting this current school year's data from our partners over at ISB. And so we'll be sharing that as soon as we can. But as we were looking at the last school year and the school year prior, we saw that the vaccination rate for measles at least was overall stable. But again, as a reminder, we've been seeing a decline in vaccination rates in our children starting in around 2017, 2018. This really applies to all of the childhood vaccinations. So work that we need to do to make sure that our families, our students, and our communities really understand why we want everyone to be vaccinated. So continuing again with measles, and again, using measles as an example of the trends that we've been seeing in terms of child vaccination rates here in Illinois and across our country. Illinois has been under the United States average for kindergarten for MMR vaccination rates. Those rates have been declining, although in the last season, we did see a slight uptick actually in the last school year. That's not reflected here, but we never want to be below average. So more work to be done there. And I'll tell you a little bit more about how we're looking in the early childhood space for this. But as we have had measles cases across the country, we're still seeing measles. We are at risk of losing our elimination status here in the United States. Canada, our neighbors up north, lost their measles elimination status. And we really need to continue this momentum to make sure that our children are getting vaccinated. So before I move on to the early childhood space, a little pause because it is the holiday season and we know that many people will be traveling, many families. So just don't forget that we do have travel guidance for measles. Make sure that your patients and your communities are aware of this. If anyone is unprotected from measles, like many other vaccinations, it takes about 2 weeks to get full immunity. So we want them to get vaccinated before their international travel. We are still seeing outbreaks in various parts of the United States. So if anyone's traveling to those domestic areas, they should also check and get vaccinated as well. I just wanted to flag that we do have measles-specific vaccination guidance for travel on our measles website, dph.illinois.gov/measles. So for all of the details on who should get vaccinated when, you can go there. But for international travel, one thing I will flag is that our 6-month to 11-month-old children, they should go ahead and get that vaccine dose before they travel. That dose does not count as part of their routine childhood vaccination series. So when they turn 12 months old, they will need to get that first dose, and then they'll need to get the second dose as well. So don't forget, if a child gets their first dose of measles vaccine before they're 12 months old, it doesn't count. They need to still finish out that 2-dose series. When a person returns from international travel or going to a domestic area where there's a known outbreak, they should monitor for signs of measles for at least 3 weeks. So please make sure in your clinics that you are counseling your families on this important monitoring of symptoms. And of course, if they have any symptoms of measles, they should contact you, and you should be contacting your local health department. Again, for school-based children, we have our school vaccination coverage dashboards. I found it very helpful in engaging with different community members about how the schools are doing and how we're doing here in Illinois. As a reminder, we created that measles outbreak simulator dashboard where you can look at a specific school and get an idea of what would happen if a child or a staff member with measles comes in, how big the outbreak would be, how long will it last, how many children will it affect. So I think another good tool as you're trying to message out the importance of vaccination and what could happen if someone with measles comes into a school. And then as a reminder, we did develop a mini toolkit for you clinicians that helps with decision-making, algorithms. So please make sure to check that out. We want to make it as easy as possible for y'all as you're caring for children or anyone who might have symptoms of measles. And we're your partner here. So don't hesitate to reach out if you have any questions about that. So turning back to vaccinations, I mentioned that we've been closely following kindergarten vaccination rates. Kindergarten in part because that's oftentimes the first entry into school where now they're having all these vaccine requirements. But we know that these childhood vaccines, they're due earlier in childhood, starting at birth. So what we did do is we worked with our Illinois Head Start partners to create a dashboard. Now, this dashboard doesn't go into as much detail as our school vaccination coverage dashboard because of the nature of the data that they collect. So they are required to collect whether a child is up to date, just broad strokes wholesale. Are they up to date on all of the CDC and now Illinois required immunizations? And so if they're missing just one dose of something, then they will be considered not up to date. And we don't have that individual vaccine level data yet, but I think this gives us a good idea of how our younger children are doing in general. So you can see that last year, only 65% of children were up to date on all of their recommended vaccinations. And so more work to do there in that early childhood space. So don't forget, it's not just about those school-age children. We really need to start this conversation and this engagement earlier on. So moving on, hepatitis B. So I was just actually telling some colleagues that earlier today, another colleague said happy Thursday, and I totally heard it as Hep B Thursday. So you can tell that this is top of mind for us. So we really want hepatitis B to be a priority for all of you. So these are all information and facts that we've been trying to make sure our communities know. But 50% of people in the United States have hepatitis B and they don't even realize they are infected. 90% of newborns and infants infected, they're going to develop chronic hepatitis B. And then 25% of those with chronic infection, they'll die from chronic liver disease, whether it's cirrhosis or liver cancer. But as you all know, this is totally preventable through vaccination. And since universal newborn vaccination began in 1991, the hepatitis B infection rates among US children dropped by 99%. So really a success story there. So what's happening with this hepatitis B dose at birth? Well, no changes. So earlier this week, our Immunization Advisory Committee met. They reviewed all of the data that's been out there, a very extensive data review. We looked at Illinois data as well, and they gave us recommendations, no changes. So IDPH, we reaffirmed the recommendation for universal hepatitis B vaccination at birth for all children. And so the ACIP had put out that independent or the individual decision-making recommendation for hepatitis B for those infants who are born to individuals who are hepatitis B surface antigen negative. We are saying that this is a firm recommendation still. Everyone should be getting this universal hepatitis B vaccination at birth. We issued a health advisory just reviewing all of the current guidance on how you're supposed to manage infants who may have been exposed to hepatitis B at birth and those who are not exposed. So please check it out. It's a comprehensive guidance, and we wanted to put everything in one place for you. We have all of our references there too. The other thing I just wanted to highlight is that for all of the other routine vaccinations, whether it's for children or for adults, we are reaffirming our recommendation to follow the CDC schedules as they were revised on August 7th, 2025, because that is the most comprehensive with some of the newer recommendations from the prior ACIP. We have links to those old documents. So these are going directly to the prior documents, not the current CDC page. So please go to dph.illinois.gov/immunization to find Illinois' current recommendations for routine vaccinations for both children and adults. For our respiratory virus season guidance, we did reaffirm that as well. It's all on this page, and now our hepatitis B guidance. The other thing I just wanted to point out, as you may have heard, you all as clinicians, as healthcare providers, are the most trusted source of vaccine information. Sadly, the CDC and state government and health departments are getting lower and lower on the list. So we really need your partnership. We know that we already have your partnership in messaging out this important vaccine information. So thank you, but just wanted to affirm the fact that you are the top trusted messengers. So making sure that families have those one-on-one conversations about any concerns that they have, listening to them, hearing them out on those concerns, and making sure that they have accurate information. So thank you, and please continue doing all of that. Okay, now moving on to congenital syphilis. So another one of those infections that we can absolutely prevent. We should have 0 congenital syphilis cases in Illinois, but unfortunately our case numbers are continuing to rise. So in 2023, we saw 102 cases of congenital syphilis. 2024 data is still preliminary, but as of this time, we have it at 113. So those numbers have increased, and we know that across the United States, that for the 12th year in the row, the United States congenital syphilis case number also rose in 2024, but again, absolutely preventable. What I wanted to show you here, so on the left, you can see in the bars, the Illinois case count for congenital syphilis. On the right, you can see on the line that's showing our congenital syphilis cases, and then the bars are actually women ages 15 to 44 years who were reported as syphilis cases. And you can see that, again, the 2024 data is preliminary, but it looks like there were fewer cases of syphilis among women aged 15 to 44 years in 2024 as compared to 2023, yet the congenital syphilis case counts continue to rise. So a lot of work that we need to do to make sure that our pregnant individuals are getting appropriately screened and that they are getting treated appropriately, and then that we're really making sure that everyone has access to prenatal care, interconception care, all of that. Because what I did want to point out is over 40% of these congenital syphilis cases in 2024, as we were reviewing, there were missed opportunities. Again, whether it was lack of access to prenatal care, inadequate treatment of a known infection, or for some pregnant individuals, their first test might have been negative, but then they got infected subsequently in pregnancy. So as a reminder, for prenatal testing, you should be testing in the first and the third trimesters. Absolutely. It's not a risk-based testing for the third trimester. Pregnant individuals should get tested in the first and third trimesters. We recently had an amendment to the Prenatal Syphilis Act here in our state of Illinois. It goes into effect January 1st, but it clarifies the timing of the required third trimester testing as between 27 and 32 weeks of gestation. Again, we don't want to miss the opportunity to identify a case of syphilis in a pregnant individual so that they can get treated and prevent passing on that infection to their children. There's been a bicillin shortage, and I know it's been really, really challenging for clinicians out there. And bicillin generally is the only recommended treatment for syphilis in pregnancy. And the shortage was exacerbated by Pfizer they voluntarily recalled some lots of bicillin. But just wanted to remind again that extensilin is being temporarily imported and may be used in pregnancy during times of bicillin shortage. It is recommended by ACOG, so it's okay to use that as an alternative if needed. And then really because we want to preserve our bicillin for pregnant individuals. For non-pregnant adult patients, don't forget doxycycline may be used as an alternative. All of this syphilis treatment guidance is in the 2021 STI treatment guidelines from the CDC, so please make sure to frequently reference that, and we'll continue to update you as we hear any updates to the guidance or regarding bicillin or anything else. I want to remind you too that we have this perinatal syphilis swarm line. It is such an amazing resource. I think I've gone to now 2 AAP national conferences where pediatricians are lamenting the fact that it's really hard to figure out like prior test results and whatnot. But here in Illinois, we have this warm line where you can call and you can get clinical guidance from a specialist, so maternal fetal medicine specialist, infectious disease specialist, on how to manage a potential case of congenital syphilis or a pregnant individual who might have testing results and you're not sure what to do. Please call. We can help with public health record searches for past syphilis testing as well, treatment results and all of that. The warm line folks can help with reporting and with other resources for home treatment. And so the warm line is available Monday through Friday, and the calls are answered by 1 business day. So a really, really great resource that we have in Illinois. So please make sure to utilize it. Just one final reminder about syphilis. We have a bunch of information, toolkits. We'll make sure the slides are shared and you can link over to our syphilis action toolkit. So then very quickly switching over to a couple of other non-infectious disease topics related to children. As a reminder, for lead poisoning prevention, again, an absolutely preventable thing here for our children. We recently expanded the list of high-risk zip codes, and in 2026, we are anticipating that we will be moving to universal childhood lead testing. And so again, those high-risk zip codes are listed on the back of the childhood lead risk questionnaire. So it's not something that you need to just memorize or try to go searching for. And the other thing is sometimes it can be a little bit tricky. Okay, like when do I have to, like everyone should be getting screened, right? And until age 6 years, but then when do you actually have to do a test versus just the screening or whatnot? It's all just do the questionnaire. It will guide you, the yes, no's, and then you'll know what you need to do. If you like tables, we also have a nice table that kind of goes through like, is their zip code high risk? Like, are they a Medicaid insured child? Like, what's their age? And then it'll give you the guidance. But again, this childhood lead risk questionnaire is one I use all the time. It actually guides you through whether or not you need to do testing. So again, a preventable thing. Don't forget to do the testing. We did see lower rates of testing during the COVID pandemic. We're still seeing lower rates of testing. We really want to make sure that all children are able to get the resources that they need should their blood lead level be elevated. Okay, and now finally, I'm just going to end with just touching on a couple of behavioral health resources. So the first one is Beacon. So as you may recall, this is a centralized portal where families can go to find behavioral health services. They also have resource coordinators. And then once they're in that system, it actually helps track share data between healthcare providers, care providers. It's a really, really nice tool. And especially for youth who may need help finding residential services or more of that acute care or more intensive services. So how does it work in terms of like for a clinician? So again, Beacon is for families to use, but you could certainly in your clinics assist them with going through the Beacon portal themselves, but it needs to be initiated by the family themselves. But again, it creates a case. A resource coordinator will reach out to them to kind of give them that one-on-one help if needed. And it really, I think the great thing is it helps track progress. So of course they get all the appropriate consents to share data. And this is a way for also pediatric healthcare providers, if you need to, you'll be able to work with the family to track progress, see where referrals are and all of that. And it's supposed to be a tool to not only connect to resources, but help all of the various care members of a child's team to be able to talk and know what each other is doing. So beacon.illinois.gov, it is in constant improvement processes. So if you have any feedback, please provide them, but don't forget to let your families know and also let your care teams know that this tool is available. And then finally, don't forget about the Illinois Doc Assist service. So it's statewide, and we know that many primary care pediatric healthcare providers are having to do mental health care. But if you have that tricky case and you're not sure what to do, call Doc Assist because you will be connected to a psychiatric specialist. They will walk you through. I will say from personal experience, it was very hands-on. They did a follow-up with me to make sure. And so utilize this service. It's for healthcare providers, it's for school-based clinicians. It's a really nice way, especially if you're on that primary care side of things, to be able to connect to a psychiatric specialist. So again, thank you for all that you do. And I am now happy to pass it over, I believe, to Dr. Spencer.
We cannot hear you, Hillary. If you can make sure.
You still can't hear me?
Yes, we can hear you now.
Oh, okay. That's not sharing the right one. Okay, take 2 or 3. Thank you for your patience. I am just going to give a brief update. We recently talked about foodborne illness, and as we're recapping the year, I was just going to highlight a couple of outbreaks and just some reminders about foodborne illness and the role that clinicians have in responding to foodborne illness. So recently, over the last couple of months, there's been a response to contamination of ByHeart formula, one of the sort of less common widespread formulas. This was recalled due to contamination with Clostridium botulinum. And as a reminder, there are a handful of different presentations of botulism. Often when we think about botulism, we think about foodborne botulism. This is preformed toxin in food that is consumed typically by adults. And there is, you can also have wound botulism where a wound becomes infected with spores and toxin is produced. Very rarely there's adult intestinal colonization when adults consume spores and toxin is produced in the GI tract. This is uncommon and usually occurs in people with other underlying bowel conditions. We have seen over the last few years more iatrogenic botulism that comes from medical uses or cosmetic uses of botulinum toxins such as Botox. And then this recall of the formula was due to an outbreak of infant botulism, and it's a unique sort of presentation of botulism that happens in young children, particularly infants, and usually young infants, most commonly under 6 months. And this is more similar to that adult intestinal colonization when infants consume spores. It colonizes the gut, and then toxin is produced, and babies present with botulism. And I put a little honey bear here because commonly we think about infant botulism as associated with honey, and that's the reason that infants don't, it's advised that infants don't eat honey because it can sometimes be contaminated. While that's sort of the classic association, most infants that we see with infant botulism did not consume honey, and often we do not find the source of the source exposure to botulism. It's in the environment, it's in the dirt, and we don't know exactly why there wasn't necessarily a contaminated product or a specific product exposure. But botulism is a paralytic condition that's characterized by acute afebrile symmetric descending flaccid paralysis or weakness. And as of December 17th, there were 51 cases of this infant botulism associated with the ByHeart formula. 2 of these cases were in Illinois, and there were also 51 hospitalizations, again, with 2 of those in Illinois. 0 confirmed deaths, and there are cases across 19 states. And fortunately, there have been no new cases reported over the last week. So this is up to date, but fortunately the cases have dropped off. And that is due to the recall and then the time that it takes for exposed infants to present with symptoms. So after consuming the product or whatever else they sort of came into contact with, they can present it within usually around 3 to 30 days. So we've now exceeded that 30 days since ByHeart was, the formula was recalled. So initially 2 lots were recalled, but as of November 11th, all lots of this product were recalled, and there should be no product for sale on shelves, and it should not be used in other settings as well. So in terms of the clinical response, for infants that are asymptomatic but who consumed this formula, there's no testing that's indicated. That's a common question that we get. There's a lot of family concern and clinical concern that infants who have consumed this, what the status is. There isn't any testing that can be done in an asymptomatic infant. The recommendation is to mark the product as do not use, and if possible and safe to do, store for 30 days. If it can't be stored safely in a way that, reliably can be assured that the infant won't be fed this formula, then it should just be discarded. And now at this point, we're far enough out that all of the products should be discarded. It's recommended to wash and sanitize items and surfaces that may have touched recalled formula, and make sure not to buy, any more of this. All lots have been recalled, and it should be off of shelves and off of web stores and that kind of thing. But if for some reason you see it, don't buy it. In symptomatic infants, don't wait for testing to treat. Call the Infant Botulism Treatment and Prevention Program, or IBTPP, which is a program out of the California Department of Public Health to consult and initiate approval for Baby Big, the antitoxin that's used for infants. Call your local health department to report and initiate testing. And notably, testing cannot be requested unless Baby Big has been released. Testing is done with a stool or enema specimen, and usually with serum as well. And this is just a note because this is a question that comes up quite frequently too, is when you'll get results. And because this is done very specialized testing and is also done at a reference lab in Illinois. We send this to a reference lab in Ohio. For those reasons, it takes quite a while. So typically 9 to 17 days. If the result is negative, that's usually confirmed in around 9 days, and it takes around 17 days for a positive result, and that's because of all the confirmatory steps. So this is just a little diagram to show some of the steps that it takes, but the stool or enema sample has to be transported. That takes a little while to get to the IDPH lab, and we have to coordinate that with the clinical lab where this is done. From the IDPH lab, it goes to the reference lab in Ohio. And then at the reference lab, it has to go through sample processing. And then these lighter blue are the 3 sort of endpoints of the testing that are done. There's a mouse bioassay that's done with the initial processed sample, and then the sample is also further processed for and cultured for isolation, and a confirmatory PCR is done on that isolate if the isolate grows. There's also liquid culture enrichment that goes onto another PCR screening, and if positive, it's further processed and another mouse bioassay is done. And this is live mice, and it requires multiple mice and multiple steps and observation, and is an in-depth process. So this picture on the left just shows a little bit about how the mice are observed and how that test is interpreted. And you can see that, that's a complicated process. So just to say that if you have a patient, whether that's infant botulism related to BiHeart or other cases of botulism in the future that you submit, just sort of a little bit of an understanding of the time that it takes and the process that it takes. And this is why, if you suspect botulism, treatment should be initiated and not wait for the results of testing. Another outbreak that I wanted to share a little bit about as we recap this year is an outbreak associated with raw milk. So we put out this, the health department put out this press release, IDPH issues reminder about potential hazards of consuming raw milk. There were 61 ills due to raw milk contaminated with Campylobacter. 15 of these cases were lab confirmed, and another 46 were epidemiologically linked to these. And most cases came from Livingston, McLean, and LaSalle, and additional cases came from across 10 counties, so 13 counties with cases. Onset dates ranged from 10/13 to 11/22 with a median of November 3rd. So we're getting a little further out and haven't seen any new cases recently. Purchase dates were here from 10/10 to 11/19, and age range was from 1 to 75 with a median age of 31. Notably, 10 cases were in individuals 6 or under. And symptoms included 21 who reported bloody diarrhea and 9 who sought care in an emergency room. So just a little reminder about Campylobacter. It's often sort of thought of as a, sort of self-limiting illness, and it can be. So campylobacterosis is a diarrheal illness that may be bloody and can have fever, cramping, and vomiting. And usually, for most people, it's self-limiting within 1 week. But some individuals have more severe presentations, such as bacteremia, and this is more common in the young, under 5, older individuals over 65, people who are pregnant, and people who have otherwise weakened immune systems. People can present with abdominal pain that mimics appendicitis or intussusception, and that can lead to higher levels of care. People may have severe or persistent infection, especially those who have immunocompromising conditions or other bowel conditions. And this may mimic inflammatory bowel disease and lead to additional workup such as scopes and biopsies and what have you to confirm. So there are also other post-infectious complications related to sort of immune responses as well. So just to say, it is not always a self-limiting or simple illness. This is just a quick reminder about where you can go to find recalls that are made at the federal level, which affect us here too. Just a reminder of where you can find those. And a quick note about reporting. So reportable cases of foodborne illnesses are due to the conditions here listed on the left. And that's a clinical responsibility, provider responsibility to ensure that those have been reported. You can also report suspected outbreaks. If you suspect an outbreak, you're seeing multiple people, sick people or people with a similar exposure, report. Also, as we're headed into the holiday season, a reminder that we're headed into norovirus season, and make sure to wash your hands, use bleach or other products listed on the EPA List G, which are approved products for norovirus. And just on that, reporting, know what to report in addition to enteric pathogens and foodborne illnesses. You can find this stop report of all of the Illinois notifiable diseases and conditions. And these are conditions that are required to be reported by clinical providers. They may be reported by your lab or another administrative partners within an agency such as infection prevention, but ultimately clinical providers are responsible for making sure these are reported. Report to your local health department and make sure you have information about the reportable disease, exposure information, vaccination history, household contacts, and especially vulnerable household contacts if available, as well as occupational history when relevant. And that's just a brief recap of foodborne illnesses and recalls this year. And I will hand it over to Dr. Kennard. Thank you.
Hi, everyone. Okay, I will bring us home here. Okie doke, let me get my presentation going. All right, I'm going to just do a quick recap of the statewide standing orders, as well as a little word about cancer cluster investigations, which I talked about last August. So I just want to remind everyone that Director Bora of the Illinois Department of Public Health has signed multiple standing orders, which I'll show you right now, that allow people and entities to, in a timely manner, obtain life-saving medications when they're needed most. These standing orders all have pretty in-depth instructions as far as who can utilize it, what the requirements are, and so forth. And so there's a QR code on each of the slides that link to more information. I'm not going to be able to go super in-depth here, but just as a reminder. So first one I wanted to talk about is the one for opioid overdose reversal agents, which are naloxone and Narcan. And so I just wanted to mention that I see we're getting down to our last 5 minutes here, so I will speed up. This allows trained personnel, healthcare and other trained personnel to obtain, dispense, and administer these life-saving medications. There's a really nice chart in the standing order for that describes the different formulations of these medications and then how they can be used. And then I just want to point out our website has a lot of great education and training materials that you can refer to when you're trying to set up your own programs. Oh, one thing I wanted to go back to, sorry, really important here is that libraries were added as a location where these opioid overdose reversal agents are available, as well as now beginning in January of this year, public libraries that fall underneath the Illinois Local Library Act will have these on site and all of their and trained personnel available so that if someone has an emergency on site, they'll be able to administer it and potentially save their life. Next, earlier this year, an order was signed by Director Bora to provide HIV pre-exposure prophylaxis that pharmacists who've had training can go ahead and prescribe this, dispense this, excuse me, for any Illinois resident that is in need. And we do have, again, information on our website about what the risk factors are for people who are HIV negative. And might be at risk of being infected with HIV, including they are having sex without multiple partners, not using a condom, a partner who's HIV positive, and so on. And so once more, links to more information. Reminder that schools also are allowed to have albuterol on site that's undesignated, meaning not designated for a particular person, so that if somebody has respiratory distress, trained personnel are able to administer it. And then finally, that wonderful from 2023, still effective, that pharmacists are able to dispense to women underneath the standing order from Director Bora contraceptives, a 12-month supply. And there's some criteria that they have to have had training and so on and so on. But really, this is making it easier for women to get access to contraceptives, as well as helping to reduce unwanted pregnancies. And then my last quick note is just a call out to the Illinois State Cancer Registry. I wanted to talk a little bit because periodically we get calls from residents or from some of you on this call about potential perceptions of potential increased cancer cases in the community. And so of course that's very concerning for everyone. And we really do have a process in place to evaluate those situations. It's based on the Illinois State Cancer Registry, which has gold certification for 27 years because of the completeness of their records. More than 2 million cancer cases are in there, and they're the only population-based cancer information in Illinois. Since 1986, multiple healthcare entities are mandated by law to report cancer. It's from the diagnosis through treatment, and unfortunately, if there's a mortality, 6 months or within 6 months of diagnosis or 4 months after discharge. And then we have guidelines, which I don't have time to talk about in depth because I know we're down to our last couple of minutes, but these were published in 2022. I have a link here by CDC and ATSDR, and they include criteria and decision trees for responding to community cancer and environmental concerns. It does not address occupation-related clusters. This is really talking about the community, and I want you to pay attention to this slide because there are some things that we need to think about whenever there's a potential cancer cluster. What is it? What do we look at? We look at a greater than expected number of the same or etiologically related cancer cases. So for instance, we might get a concern that there's brain cancer, but it's multiple different kinds of cancers. They're not necessarily related and so on. That might not qualify, but greater than expected number related cancer cases within a group of people, you're going to have what's the demographic area and demographic group, excuse me, and the geographic area over a set period of time. And then is there some potential environmental concern that could be potentially linked to those cancers? So all these points need to be taken into consideration. Number, type of cancer, group of people, geographic area, time, and what might be the etiology. And then there are limitations, people moving in and out of the area and so on. I don't think I have time to really talk about that much, but just realize that even if all those criteria aren't met, we will look at the situation. We will do an investigation with the cancer registry and other, our epidemiologists and so forth, the medical services division, to take a look at these. And the last point is just that it requires sensitivity and concern, because people are very concerned that their children might be harmed, they might be harmed by something that's going on in the environment. So we really do take a close look at everything, work with our federal partners, and there are a lot of resources that can help you all as far as communicating in these situations. And that's all that I have. Thank you. Sorry, that was a bit of a whirlwind there.
I know people have to drop off, but I just want to say you will get to hear more about Dr. Kunar next month when we do our next PHACT series. But I just want to say, look, we are here for you. We're here for your community. We're here for science. You've joined us every month, and we really cannot thank you enough for that, for being part of our, allied public health allied clinician series. So this is the next one. You can register here when you get the live links. And I just want to also just put it to the last slide where the QR code is for the CME link. So if you could just click on the QR code, I'll keep this open for a minute while I know people are still hopping off. So again, I just want to wish everyone wonderful, happy holidays, no matter what you celebrate. And hopefully you enjoy whatever it is whatever form of holiday you celebrate over the next few months. So take care, and we'll see you again in the next year. Bye, everyone.